I'm going to be talking about how can we facilitate the best outcome for individuals who have eating disorders, who have had to take a leave from school and college, and now they're returning back to college. So my focus is going to be on that. And I'm going to start with a general overview very quickly in terms of why we're going to need a multidisciplinary team. Unlike other psychiatric illnesses, eating disorders have significant medical complications, so the need to always have a medical person as in the team is essential. What we worry about with eating disorders is primarily cardiac issues, bradycardia, low heart rate. We have some guidelines in terms of inpatient admissions for adolescents under 50. You want to seek advice of emergency room for possible hospitalization. And with adults, we get concerned under 40. Electrolyte imbalance, when someone is binging and purging, you get concerned about potassium level dropping. So, and the amenorrhea, osteoporosis, osteopenia, those are more longer-term consequences that you worry about with this patient population. But the first two are what you really have to be paying attention to. So the need for a psychiatrist and your team. There are comorbidities with eating disorders, anxiety, depression, social anxiety, very common. OCD, 15% of restricting type anorexic patients struggle with bona fide OCD. With bulimic patients, we see more impulse control related difficulties. Alcohol, substance abuse is common, self-harming behaviors, borderline personality disorder. 30% of eating disorder patients also have a history of trauma, which is the same as any other psychiatric illness. A lot of people ask whether trauma is more common in eating disorders because we are dealing with body image issues, and the answer is really no. If you have a trauma history, you're going to develop something. Could be substance abuse, could be depression, could be eating disorder. Eating disorders are not about food, but they are about food. You have to address the food issue, and definitely you do need a dietitian as part of that team with the aim of normalizing the eating, weight restoration, paying attention to refeeding issues, and activity level. At what point individuals have to get involved with certain activity levels. So multidisciplinary team is needed to pay attention to medical stability for these patients, medication management if someone is, again, has depression that requires being on an antidepressant, or we know certain, Prozac at 60 milligrams is also helpful with managing bulimia. Nutrition rehab and psychotherapy that can take different forms, individual therapy, group therapy, family therapy. There's always resistance to treatment. Unfortunately, this is an illness that involves minimizing and denial and resistance to treatment. I think it is important for individuals who are under 18, definitely to have parents involved. They have to be involved. You can't do really treatment without the parents' involvement and permission. Over 18, I think if you can get the parents involved, family involved, it's really essential. We're going to talk a lot about college students and middle school and high school students, especially if the college students are living with their families. We get them involved in our center even if they are in their 20s and 30s and living with their family. We really want to get the help of the family to support them in their recovery. Goals of treatment, restoration of weight, normalization of eating, and again, paying attention to why someone has developed an eating disorder and helping them with changes in their thoughts and behaviors, and focusing on relapse prevention. And I think that's what brings us to today's talk. And so I think anyone who's has an eating disorder is considered high risk. Eating disorders can become chronic, and I think we consider them at risk. Even if they are at a better place, there's always possibility of relapse. In terms of school counselors, They can learn to, I think that it's important to have one or two who can be trained in being able to identify eating disorders, diagnose someone who has an eating disorder, be aware of the medical complication. Again, if you have a nurse in the school and the heart rate is low, for them to know that this is an individual that you should send to emergency room. And if someone is purging a lot, to be able to make sure that they get their electrolytes checked. Be aware of the warning signs of the eating disorders and risk factors. And I'll talk about the risk factors, and provide support for recovering individuals. So they do play a significant role. I think Cameron just talked about dieting being a trigger for development of an eating disorder. 35% of normal dieting gets into some pathological form of dieting. And of those, 20 to 25% develop into partial or full eating disorders. So that's significant. So if you are seeing someone who is dieting in a diet mode, you want to pay attention to that. That it may not develop into anything, but it might. It's one of the triggers. And of course, athletes, I think you probably talked a lot about that. There are some behavioral behaviors that can, I think counselors in school settings should pay attention to, that might indicate someone is struggling a lot with eating disorder issues. We see focus on healthy eating, a lot of energy drinks, supplements, calorie counting. It's not, it's very common to hear nowadays about someone becoming a vegetarian or vegan, and you have to do a good assessment to make sure it's not a result of an eating disorder, wanting to cut fat, protein, and stay with a very low-fat calorie diet. There's a lot of obsessive thinking about food, skipping meals. I think that can be observed, especially in boarding school situations. Avoiding food in social situations, so kids who avoid going to cafeteria and are not eating. Oversized clothing that they wear, complaining about food allergies. That's also very common with eating disorders. Nowadays, everybody has allergies, and you really have to assess to make sure it is a true allergy. Excessive exercise and checking their weight several times, body checking. And in terms of the more the psychological aspects, what to be aware of in, as school counselors, what you're going to see are, the profile of what we see with our eating disorder patients. Perfectionistic, can be very rigid, overly responsible, very black and white thinking, they can't shift. They have a hard time shifting. Mood swings if they're binging and purging, you see that a lot. They can be very irritable, cranky. If they're not eating, they're irritable. These are kids who are they can be your perfect students. They're doing everything right. Very much scanning their environment for approval, and difficulty expressing their emotions. And social aspects, you pay attention to isolation. Are they isolating? Are they in rooms? Are they not interacting with their peers? There's especially there's avoidance in areas that involve food, and because they could have a very strict dieting schedule, strict food schedule, when they can eat, what they can eat, how they can eat, and also exercise. We get individuals who are quite compulsive exercisers. They might be exercising in the morning, exercising during lunch, exercising before dinner, exercising after dinner. So it gets in the way of being a social being and being able to interact with their peers. So how to deal with an at-risk adolescent? We know early intervention is crucial to recovery. And being able to show support and concern, not being critical, not being pointing fingers. I think that's not going to get you anywhere. You want to come from the perspective that this is very difficult where they are, so it's showing empathy and understanding. But also holding the line. if you are seeing a student who is engaging in behaviors, you don't want to ignore that. You really want to address it in terms of, it's come to my attention that you're spending 4 or 5 hours in the gym. I'm concerned about your health. Or it's come to my attention that, we don't see you in the cafeteria. You're not eating. We need to talk about that. So being able to address it, not wait for them to bring it to you, but if you are seeing things, you need to address it. Remember, with the eating disorders, there's denial, there's minimizing. I'm at a good weight, I'm eating healthy, it's not an issue. So you want adults in this setting to be able to identify it and address it. And then refer them to resources that can provide assessment and treatment. If you're not sure about your assessment, you can always refer them out. Relapse rates are quite high with the area of eating disorder, and that's why I say every individual who has had eating disorder is really considered at risk. This is a meta-analysis of many studies that was done, and with anorexia, 46.9% are fully recovered. 33.5% are recovered partially, 20.8% become chronic, and of those, 5% mortality rate. This is looking at 126 treatment outcome studies. With bulimia, it's 47.5% recovered, 26% recovered partially, and 26% become chronic. So in terms of colleges, or even high school students and middle school students, really there are 3 categories of students that are entering systems that you have to worry about and think about how can you provide them the best transition. So you have someone who's gone on medical leave, school has asked them to leave, or they have gone to that conclusion that they need to take a semester off, they leave in the middle of the semester. They do some treatment, they're coming back. Then you have someone who finished school, finished the semester, took the summer for intense treatment, and now is returning back to college or school, middle school, high school, or boarding school. And then you have a third category of students that you may not know much about them unless the family has notified you. These are new students that are coming to your system. Just this morning, I got a call from a school. It's a college preparatory school, and they took this student just this fall, and the family didn't tell them anything about this significant history of eating disorder. And now their whole community is disrupted. They're finding vomit everywhere. It's in the room, and they had to say, you need to leave right now. So they had called to see what they could do in treatment and helping them with that. But they had no idea. They had no idea. So there are also this third category of students who you don't know anything about them, but they're coming with a lot of history of treatment, and they are at risk. So historically, the response of schools and colleges has been to mandate treatment. You need to get treatment, whether it's you need to see a therapist, dietitian, see a doctor, or removal from school. Schools were able to mandate medical leaves. In 2011, that changed. Department of Justice issued a ruling that says you can't do that anymore. If someone is at risk of hurting themselves, you can't ask them to leave. You can if they are going to hurt somebody else, so this has changed the schools a lot. I hear complaints all the time from colleges about this ruling, that it really ties their hands, and they have very, very sick patients in schools, and they can't do anything about it. They're finding ways to get around it, that the health and counseling services don't have to do that. They start getting the administration getting involved, and there are ways that if the dean and the administration gets involved, you can still, with the advice of the legal team, you can ask them to leave. But I hear a lot of complaints about this ruling, and I think they're hoping that it would change. A lot of colleges talk about how they're not psychiatric settings, but they're expected to take care of very psychiatrically ill patients. So And living on campus, historically also they could ask someone to leave the dormitory if they were disruptive to the environment. And the challenges in terms of providing support for students who are returning to school, sometimes there is a deliberate effort on the part of parents not to inform schools that their kid has had eating disorder, has had significant treatment, has just left the residential program or inpatient. We get a lot of calls during July and August from parents who their kids are starting school in Boston area, and many times based on the universities, I would recommend them getting services within the university, and I can't tell you how many times they say, well, we don't want the school involved at all. It's like, but Harvard has a great University of Health Services. Someone can really take her weight, they can be on top of this. No, we don't want the school involved. And I think it was the fear that if the school is involved, they're gonna ask them to leave. I don't think it's the best decision. You want your kids to be under supervision, under care, oversight, and get the best care that they can get, as opposed to not having resources available to them that are very easily accessible. So we have seen that deliberate avoidance, and talking to universities, they are aware of it and can't do much about it. And getting college students and overachiever adolescents involved in treatment is very difficult. Again, these are your overachievers who are doing everything and anything besides the academics and the classes that they're attending. So they don't have time. They'll tell you that. They're struggling a lot. It would be great for them to have an outpatient team that's complete, that has a dietitian, therapist, psychiatrist, physician, or maybe add an intensive outpatient program to it. And it's very difficult. They don't have time. Treatment is not a priority for some of these students. So in terms of the challenges that the universities are actually facing in terms of providing care to these individuals, there is a survey that the National Eating Disorder Association did of the colleges, and 85% of colleges, they said they really lack resources to provide care to individuals who struggle with eating disorder, who are on their campuses. Lack of funding, limited funding, lack of staff who are trained in eating disorders, and lack of time. Again, these are patients that it's not an anxiety patient that you see once a week, once every other week, or a student who's stressed out, that you provide some support and care and they get better. These are individuals who you have to worry about their electrolytes. You have to make sure they're getting weight and they're not losing weight. So it does take a lot of time, and they don't have the time to spend with these patients. The stigma associated with eating disorders prevents a lot of college students attending some outreach programs and programs that the universities do. Sometimes many of the universities may have group therapy for eating disorders, and they have a very hard time getting students to those groups because the students are afraid that they might see someone else from their class or from their dormitory. Universities that do, again, outreach to their student population find it very difficult to have them attend because, again, they're afraid that they're going to run into somebody that they know. And students, less than 20% of students who have been screened positive for eating disorders report receiving treatment. That's significant. 80% are not receiving treatment. And again, these are not your straightforward psychiatric patients. You're dealing with individuals who can have serious medical complications, individuals who don't take care of themselves well. They push themselves. They don't pay attention to the symptoms that they get. So you really need oversight that helps them to do better self-care. So inadequacies in delivery of care can result in prolonged illness, poorer prognosis, and greater risk of relapse. So, schools and colleges, they have to pay attention to being able to catch these individuals at earlier stages. Recommendations for the colleges would be to really identify staff that like the area of eating disorders. Not everybody likes dealing with eating disorder patients. That's a reality. Many individuals can't sit with patients who are resistant, are in denial. They don't take care of themselves. They make you very anxious. They don't follow the recommendations. Many would tell you, I can't do it. I'm glad there are people like you who can do it, but I can't do it. So it is good to identify individuals who like this work in college settings and give them some training. In-service trainings are good for the staff to know at least how to catch them and refer them out, how to identify individuals who may need additional services. Peer support services. Harvard University has a program that I think is really good. It's the Eating Concern Hotline. It's run by students. They do get training from professionals from the counseling services, but it's really a student-run organization, and they provide hotline support to students who struggle with eating disorders. So you can be anonymous, you can be calling this line, talk to a student who can hopefully then advise you to do the right things. They don't provide therapy, they're very clear about that. But they can be there for somebody who's struggling a lot and hopefully help them to get to getting treatment. I think it's a great model. Again, with the stigma, with them resisting to go into treatment because they might run into somebody, it's a good model to have something that's anonymous. In terms of medical care, I think some universities are equipped to have, and middle schools or boarding schools, they may have health services department, and smaller schools don't have it. With the colleges that they do have a health services department, the question would be, are they equipped to deal with eating disorder patients? Can they weigh someone on a weekly basis who needs weight checks and vital sign checks? Can they do it the right way? Can they do it in a hospital gown? Can they do it after urine-specific gravity? Again, if you're having students who you're saying if you don't gain weight or if you lose weight, you're at risk of being asked to go to a higher level of care, they could manipulate their weight very, very easily. So if you're weighing them in clothes, they can have, ankle weights, they can have tons of things in somewhere and show weight gain. Or they could do water loading, so you have to be able to know if they have done that. So I think it is important, do you have the right setup to take care of this eating disorder individuals? And the same way with repeat blood work. If you have someone whose electrolytes are off, you have to have repeat lab work done. And that's, for some individuals, it can be on a weekly basis. Are they set up to do that? And if they don't have it, or again, it's too time consuming, they need to refer them out to specialty centers or physicians who basically treat eating disorder patients and can weigh them and do the lab work as frequently as it's necessary. And again, I'm a great believer, you gotta have a medical person involved. We won't treat anybody at CDC who does not have a medical doctor as part of their team. If they don't have it, we'll give them referrals, we'll make sure that they get one, but we won't treat someone. You'll be surprised what happens when someone hasn't seen a physician and what a poor health they're in. A few months ago, I got a call from somebody, a 19-year-old, whose father is a physician in one of the major hospitals in town, and she was calling to get outpatient therapy. I need a therapist. Okay, so do a phone screening. She's binging, purging multiple times a day. Her weight is very low. She was, I think, 72, 73% ideal body weight. So first thing I said, well, first thing, you have to get a medical workup done. I don't have a physician. So we make arrangement that she goes to emergency room, and her potassium level is 1.5. 1.5. She went to MGH, actually, emergency room, of course, gets hospitalized. So this is why it's scary to work with these patients. They look normal. So you can have a normal weight bulimic. It doesn't even have to be underweight to be detected. And they don't pay attention to their physical symptoms, and they don't care enough about themselves. There's so much self-loathing that they really don't take the steps that's necessary to do good self-care. And in terms of academic areas, I think it's good for students with eating disorders to be aware of student disability services. Many colleges, all colleges have it. It can help them and provide some accommodations to them. It can become the link between them and maybe the administration with regard to medical leave, with regard to being able to hold on to their loans and have a course load that's lighter. It can help them to communicate with teachers about incompletes. I think it's a good service for students, and many are not aware of it. I think it's a good one to, especially when they're returning to school, to college, to be aware of this office. In terms of the food management, we all know that dealing with cafeteria can be a very challenging task for our college students and also the middle school and high school students, especially in boarding school situations. Making choices is very difficult for these patients, and being bombarded with tons of food in the cafeterias, it's overwhelming. For someone who has urges to binge, it's an overwhelming environment. For someone who's anorexia, it's overwhelming to make choices. So many of them are avoiding, anorexics are avoiding the cafeterias, bulimic patients are binging and purging multiple times a day. Calorie posting, I don't think it's a good idea. I know there's a movement towards that. Some colleges are using that. There are students who report they just get frozen in front of looking at the menu. They just can't make, going in there, they thought, I can do it. I just know what I'm gonna do, and all of a sudden they're looking at it and they're seeing calories. It's like, they just turn around and go away. So I think if they are doing calorie posting, there should be some other options for some of these patients in terms of a cafeteria that doesn't post it. I think it's good to have for dietitians who work with eating disorder patients to create a relationship with the food management department. We've been able to do that. They can give you a listing of all the menus that they have for the next month. Generally, they know what they're going to have, and that helps for planning for the college students to be able to, for the dietitian to sit and say, so looks like next week these are what you're going to have in the cafeteria. Let's decide what you can have and how much you can have. I think it can be a good support for them to make it less overwhelming. Living situations. Patients with eating disorder, college students with eating disorders, middle school, high school students in boarding school situations can be very destructive to other students, to the community. I think it is important in college setting for RAs to really get trained about eating disorders. I think it's good to get some in-service training to be able to identify what are the symptoms of eating disorders, who's at risk, who are individuals who are at risk, and hopefully develop a good rapport to be able to help them. At least, again, not necessarily provide therapy to them, but at least get them in the right direction and referrals. They tend to isolate, as we talked about it, so I think some activities in campus or in the dorm can be helpful to these patients who end up in their rooms and very much food being their only friend. They're not assertive, they don't take initiative in terms of creating social activities for themselves, so I think if you can make things easier for them, it's better. They can help with conflict resolution with roommates. Again, these are patients who, especially anorexics, are people pleasers. They'll struggle with something, they'll get stressed out, but they won't raise it and bring it up with their roommate. And I think a third party can be helpful with that. Universities also, again, they're in a very difficult position. They do get calls from other parents of other students. You know, we hear that complaint in terms of pressure that the administration is getting in terms of do something about this eating disorder student who is purging in the shower, is purging in the bathroom, is eating my kid's food, is making, you know, it's cutting, it's making my kid really stressed out. So I think ways to identify who are these individuals and give them the supports that they need is really crucial. And, you know, as we talked about, there are so many players when you are treating someone with eating disorders. You have your physician, you have your psychiatrist, psychologist, dietitian, family therapist. If they're in IOP, you have the IOP case manager. It's really important for all these individuals to be able to communicate with each other. Contracts, I'm a believer in having treatment contracts with patients for them to know what the expectations are. Many of them can come back to college with a contract. Others may need it, that you develop it. And the contract can be in terms of them agreeing to see a therapist once a week, to get weighed on a weekly basis, could be seeing the dietitian, could be agreeing to weight gain to, 1 pound a week of weight gain. Could be if your weight drops 5 pounds, we need to have some additional supports put in. And everybody has to be aware of the contract, and people need to communicate with each other. Otherwise, splitting is very common with this area of eating disorders. Patient would say, well, my dietitian thinks I don't need to gain weight. My physician says I can start running an hour a day. And all these individuals need to be able to talk to each other to not get into trouble with splitting. So, just general recommendations for returning students. You can't force anyone to do anything. You have to develop a rapport with these patients. It's a very fine dance that you do with this patient population all the time to get them to gradually do what they need to do. And them trusting you is very important. Multidisciplinary team, again, it's a must with the area of eating disorders, and collaboration. And them giving you permission to talk to different people. Once in a while, we'll get somebody who says, I want to do your IOP program, but I'm not going to let you talk to anyone in my team. I'm not going to sign releases. I don't want you to do it. We won't take that individual. We really can't provide good care if we can't talk to other individuals who are taking care of them. You can't operate in the dark. These are just potentially dangerous cases. Parents are in really the difficult position that once you have a kid who's 18 and older, you can send them from California to Massachusetts and pay all their bills, you have no right to any information about them. This is really difficult position for many of them, especially when they're sending a kid who has had significant eating disorder. So we'll get calls a lot in terms of, can you update me about this, my kid? And we can't do anything unless that we have a release of information signed. And sometimes, even if they sign it with certain restrictions, it's acceptable. If they can say, well, you can share this, but not that. That's okay. We always also tell our patients their parents are listed as emergency contact. If we do have concerns about their safety and well-being, we will contact them. I rather get sued for breaking confidentiality than something horrible happening to a patient. I want the parents to be notified and step in. So you heard about the values of having a contract, and that's really having clear expectations. I'm gonna do this, and you're gonna do that. You know, if you don't do this, then we're gonna have to do following things. I think that puts you in a better position in terms of providing care in a very ethical way. Social programs, I think, again, can help with reintegration of these patients. For many of these individuals, other eating disorder patients are their source of support. And I think there needs to be some help around some social gatherings, some social programs that can help them to find other ways of connecting with other individuals. And again, they're not the best ones in terms of being assertive, finding things. I think you have to make things easier, and schools and middle schools can do that. And of course, you know, anonymous peer support programs, I think those are very good for individuals who are resistant to getting to professional help. They might be at the stage 1, and some help might get them in the right direction. And I think that's it.